Debuttam, you want to wait for some more time or should we start?
I do.
Dr. Debuttam, I think we should start.
So, good evening, everyone. Good evening, madam. So, today our topic of discussion is cerebral hemodynamics and cerebral physiology, a case-based approach. First, start with a case, and then we'll discuss about the topic actually. So, there is 25 years old male with no known comorbidity had a road traffic accident. He had a head injury, and that's why he was shifted to nearest hospital. And there he was found to have low GCS, E1, V2, M3, and along with hypotension. He had a history of convulsion just after the accident. After that, CT, I mean, airway breathing and circulation was checked, and airway was secured, intubated ventilation due to low GCS status. CT scan brain was done, which showed traumatic ICH, IVH along with midline shift. Um, the IV fluid, vasopressor, antibiotic, anti-epileptic agent, and other supportive was given. Resuscitation was started. Hyperventilation, osmotic therapy, maintaining MAP was ensured. Urgent neurosurgery refer was given for surgery. Uh, Today, our topic is a discussion regarding the cerebral hemodynamics. So, in this background of traumatic head injury, we'll discuss the case, we'll discuss the topic accordingly. So, here in traumatic head injury, there is an intracranial bleed, and that causes increased ICP, and so the cerebral perfusion pressure will reduce. Our main motto is target balance between ICP reduction with adequate perfusion is the treatment for this purpose. So prior, let us start the case. I mean, let us discuss the topic. Actually, we know the human brain represent only 2% of the body weight because, but it has utilized almost 20% of the body oxygen. It has a high metabolic demand. For continuous supply of the oxygen and blood glucose is necessary for the metabolism of the brain tissue. I mean, even some minutes of interruption of oxygen or hypoxia or glucose can lead to severe brain permanent impairment. Homeostasis of cerebral hemodynamics is critical for supporting cellular function, intracranial homeostasis, and supply of oxygen and necessary nutrient. Now, some terminology and clarification. First, we know what is blood-brain barrier. So, blood-brain barrier is a consists of endothelial tight junction, basement membrane, astrocyte process, and pericytes. This blood-brain barrier selectively allows passage of small lipid-soluble molecules such as oxygen, carbon dioxide, other hormones, certain hormones, but restrict large hydrophilic molecules and most of the pathogens. This blood-brain barrier responsible for maintaining ionic equilibrium as well as the protection from neurotoxin. Function of the blood-brain barrier can be disrupted in context of trauma, ischemia, malignancy, and that can lead to cerebral edema and high ICP, intracranial pressure. Now, what is the basic principle of cerebral hemodynamics? From basic physics, we know that any current flow is depends on voltage divided by resistance. So here, flow means Q for human physiological purpose. It is the cerebral blood flow that is equal to cerebral perfusion pressure divided by cerebral vascular resistance. Flow Q is equal to pressure by resistance. Now, from Poisson equation, we know resistance is equal to 8 eta L by pi r square. That is, resistance depend on the fluid viscosity, length of the tube, diameter of the tube, and all these things. So similarly, in human brain, also the same thing works. As we think this is a linear flow, blood flow, we take it as a blood flow is a linear flow. So in that case, flow will be pi r square by 8 eta L into P, where flow, Q indicates the flow, E for pressure, R is radius of the vessels, fluid viscosity or blood viscosity as eta, and L is the length of the tube. Now, vessel's diameter, length, and blood viscosity influence the cerebrovascular resistance. As I told, cerebral blood flow depends on cerebral transfusion pressure divided by cerebrovascular resistance. The fourth power relation of the radius with respect to flow, relatively small variation in the vessel's diameter have very large impact on cerebral blood flow. Hematocrit temperature as well as the plasma composition affect blood viscosity, which in turn plays an ancillary role in brain hemodynamics. Although low hematocrit facilitates perfusion, it can impair oxygen delivery. Elevated hematocrit, on the other hand, causes increased viscosity and cerebrovascular resistance that decrease cerebral blood flow. Now, Monroe's hypothesis, as we all know, skull is a rigid closed container. It contains brain tissue, cerebrospinal fluid, and blood. Approximately, it is around weight is 1.7, which contains brain tissue around 1.4 liter, 150 ml CSF, and 150 ml of blood. Because of total volume of its content is fixed as it is a closed and rigid place. An increase in the volume of one of the component must be offset by decrease in the volumes of the other to maintain intracranial pressure. Like if a mass like hematoma or brain tumor or edema expand inside the skull, body compensate by shifting CSF out of the cranial vault and into the spinal column, and by compressing venous blood out of the intracranial space. Once these natural buffers are depleted, any further increase in the volume causes rise of the intracranial pressure rapidly. Extremely high ICP can lead to brain herniation. Now, flow metabolic coupling. When there is an increased metabolic demand inside the brain tissue, there is an increased cerebral blood flow. Increase in the neuronal activity in the brain causes local release of glutamate, which produce and release the vasodilator like nitric oxide. High metabolic demand causes local oxygen depletion, which causes release of adenosine and production of lactate hydrogen plus ion. All these have a vasodilation properties, so increase the cerebral blood flow. Use of sedative agent, rise of body temperature, convulsion, sleep, coma, exercise, all these factors affect the cerebral blood flow by influencing cerebral metabolic rate. So not only the pressure, resistance, all these parameters, apart from that, this cerebral metabolic rate also influence the cerebral blood flow very much. So cerebral blood flow is the average perfusion flow to the brain tissue. It is detected by cerebral blood flow is equal to CPP, cerebral perfusion pressure, divided by cerebral vascular resistance. Normal value around 50 ml per 100 gram per minute. Intracranial pressure, normal pressure within the cranial vault. Normal value is around 5 to 15 millimeter of mercury. Any elevation of ICP may jeopardize CPP and cause ischemia of the cerebrum. Cerebral perfusion pressure (CPP) that is equal to MAP minus ICP is around 60 to 80 millimeter of mercury. This is the net pressure gradient driving the cerebral blood flow. Usually ICP is low in normal condition, so CPP can is equal to MAP. We can appreciate it. Cerebral metabolic rate of oxygen, that is CMRO, that is oxygen consumption by the neural tissue or brain. It is around 3 to 5 ml oxygen per 100 gram of brain tissue per minute. Now, regulation of cerebral blood flow. Auto-regulation of the cerebral blood flow. So we know there is some organ, brain is one of the major organ of human body. So even there is a fluctuation of blood pressure inside the body, like the heart, brain also have auto-regulation facilities. So it is the inherent capacity of cerebral arteries for maintaining relatively stable cerebral blood flow over an interval of mean arterial pressure around 60 to 150 millimeter of mercury. With rising of MAP, vessels constrict in order to decrease flow. With falling of MAP, vessels dilate in order to restore the flow. So, in loss of this autoregulation makes cerebral blood pressure is pressure sensitive with potential for both increased danger of hypoperfusion in low pressure and as well as hyperemia when the pressure is high. So cerebral blood vessels constrict or dilated in reaction to the alternation in the pressure, maintaining perfusion constancy in the presence of systemic circulation variability. So this is the graph that showing the x-axis is the blood pressure and y-axis is the cerebrovascular flow. Around 50 to 150, it is in horizontal line. That is the auto-regulation zone. Below the 50, there is chance of ischemia, and above the 150, there is a vasogenic edema. There is a hyperemia that can lead to vasogenic edema. So auto-regulation can be lost in traumatic brain injury, stroke, sepsis, like these disorders. So this graph A shows mean arterial pressure and cerebral blood flow relation. When the MAP is higher side, there is a vasoconstriction to maintain the cerebral blood flow. And when there is a low blood pressure, there is a cerebral vasodilatation. So the flow can be maintained. And graph B showing the time along with the cerebral blood flow. When this is dynamic cerebral autoregulation curve, there is a rapid change of blood pressure can lead to this type of graph. Now, what is the mechanism of this autoregulation? So cerebral, I mean, by this time we get to know that autoregulation is a brain intrinsic property, physiological property to maintain relatively constant blood flow despite of changing the cerebral perfusion pressure. This is achieved through a complex interplay of myogenic, metabolic, neurogenic, and endothelial mechanism. We'll come details in further slides. Myogenic response involve vascular smooth muscle construction in response to transmural pressure changes. Whereas metabolic regulation influenced by carbon dioxide, partial pressure of carbon dioxide and local metabolic byproducts. Neurogenic mechanism depends on the perivascular innervation and neurotransmitter things, and autoregulation is frequency sensitive. That means low frequency blood pressure fluctuation are buffered while larger frequency may pass through unfiltered. Now come to chemical control, that is carbon dioxide and oxygen. Cerebral blood vessels are very sensitive to variation of the arterial partial pressure of carbon dioxide. As it told, blood-brain barrier, when the carbon dioxide is very easily diffuse and cross the blood-brain barrier. So carbon dioxide has a heavy influence on this auto-regulation. When there is a PCO2 is increased or hypercapnia occurs, there is a vasodilatation, and this enhances the cerebral blood flow. Similarly, when there is a drop of PCO2 or hypercapnia, there is a vasoconstriction that leads to decreased blood flow. This change of PCO2 actually causes the change in the extracellular pH that leads to release of local vasodilator and dilation or vasoactive agent that is the causes the changes in the cerebral blood flow. The response is immediate as well as reversible and is the basis of the therapeutic hyperventilation in purpose of the decreasing ICP in acute situation. Like an acute traumatic brain injury, you usually do like this hyperventilation, but it is the immediate effect, but it is reversible. After 8 to 12 hours, again the things normalize occurs. So response to oxygen PaO2 is weaker under condition of normoxia. When Pa2 level less than 50 millimeter of mercury or SO saturation level is less than 80, that induce vasodilation in order to augment cerebral blood flow. Hyperoxia is not directly associated with cerebral blood flow but can lead to oxidative stress. Now, recent MRI-based studies have confirmed that oxygen availability directly influences cerebral metabolism and perfusion. Zhu et al. Demonstrated that hypoxia leads to increase in the CMRO2 and rise of cerebral blood pressure as a compensatory mechanism in attempt to preserve oxygen delivery. In contrast, hyperoxia resulted reduction of the CMRO2 with minimal change of cerebral blood flow. This paradoxical effect is attributed to oxygen-induced oxidative stress, which may inhibit mitochondrial metabolism and reduce neuronal activity. These findings have clinical implications like excessive oxygen supplementation, particularly in ischemic or traumatic brain injury, may depress cerebral metabolism. So we have to titrate according to the need. So this is a curve of cerebral blood flow and pressure. It is a four graph. One shows partial pressure of carbon dioxide, that is blue one. Yellow one is for MAP, red one or violet one for PaO2, and green one for ICP. So if we can say for MAP, as we have already discussed, around 50 to 150, the auto regulation is maintained. MAP is 50 to 150, there is not much change of cerebral blood flow. Similarly, PaO2, if you go through, is around 50, more than 50 or more than 80 to 300 actually around, result remains stable. And what is PaCO2? For PaCO2, it around 20 to 80 millimeter of mercury of PaCO2. There is not much change of cerebral blood flow, but below that there is a huge impact on cerebral blood flow changes. Now come to metabolic regulation. So, cerebral blood flow is directly associated with the metabolic requirements of the neuron. Any rise in the activity of the neuron, neuronal activity, leads to release of the vasoactive metabolites, including adenosine, hydrogen ion, potassium, nitric oxide, and all these promote and increase the perfusion to the area. This local regulation ensures that area of brain that are being used receive comparatively increased blood supply. Now come to neurogenic control. Now, extraparenchymal pure vessels are supplied by sympathetic and parasympathetic nerve. Parenchymal vessels have intrinsic supply from the intercerebral neurons from locus coeruleus and raphe nucleus. So this difference in innervation is typical for the brain tissue, and these have allow autonomic regulation uh, only for the larger arteries, not for the parenchymal arteries. They respond to the local neuronal activity. Now, neurologic control is mainly through the autonomic nervous system as well as through the neurotransmitter. Sympathetic stimulation causes vasoconstriction and parasympathetic stimulation causes vasodilatation. So, parasympathetic action is comparatively lesser than the sympathetic vasoconstriction activity. Neurogenic modulation is more profound in disease like vasospasm or migraine, in which abnormal signaling in the neuron influence the vascular tone. Now, endothelial mechanism. Neurovascular coupling refers to the tight coordination between neuronal activity and local blood flow. When neurons become more active, they signal nearby blood vessels to dilate and increase perfusion to match the metabolic need. Endothelial cells of cerebral blood vessels are central in the regulation of vascular tone through the release of the substance like prostacyclin, nitric oxide, all these things. Among these, nitric oxide is the most potent or important vasodilator that involved in neurovascular coupling as well as autoregulation. Last is myogenic mechanism. So myogenic mechanism actually directly react to the mechanical stretch within the wall of the blood vessels and adjusting smooth muscles contraction in order to provide uniform flow. So if there is an increased blood pressure, there is a depolarization of the smooth muscle that causes influx of the calcium, and that leads to increased calcium sensitivity as well as the phosphorylation of the myosin light chain kinase. These two things leads to increased tone and reactivity of the vascular smooth muscle and causes vasoconstriction. So increased blood pressure, depression of smooth muscle leads to vasoconstriction and decrease the maintaining the cerebral blood flow. Now, how to clinical assess the autoregulation? Clinically, autoregulation can be evaluated via dynamic techniques such as transcranial Doppler or near-infrared spectrometry by analyzing blood pressure flow oxygenation relationship. Technique like pressure reactivity index, transfer function analysis, and wavelet coherence help identify individualized autoregulatory ranges. Now, pathological condition, as we discussed throughout earlier, I mean, to the first hour case, the traumatic brain injury. So traumatic brain injury causes, there is two things. Right? One is trauma that causes the brain injury. Now, there is a secondary brain injury after the traumatic brain injury. It because of hemorrhage, hypoxia, hypoglycemia, cerebral edema, hypoxia, that can lead to further aggravate the brain injury. This is secondary brain injury. So traumatic brain injury cause both primary mechanical trauma and secondary injuries. And these injuries disrupt the autoregulation, leads to increased ICP and decreased cerebral perfusion pressure. So that both of these things ultimately makes patient prone for ischemic damage. For that purpose, ICP monitoring, brain tissue oxygenation probes, advanced imaging are the management one of the I mean, for management of the traumatic brain injury is recommended. So intervention targets to decrease ICP, optimization of cerebral perfusion pressure, and avoidance of the secondary injury from hypoxia or hypotension is recommended. So cerebral oxygenation, good perfusion, maintaining good cerebral perfusion pressure, this is the main key to treat any patient of traumatic brain injury. In trauma, there is a disruption of the blood-brain barrier, increase cerebral metabolic rate or oxygen demand as well as the glucose demand. The cerebral oxygenation depends on oxygen content of the blood, oxygen consumption by the tissue, and cerebral blood flow. Now, the target is to keep cerebral blood pressure around 60 to 70. That causes decreased vasogenic edema and cerebral blood volume. So, apart from the ICP, there's a loon therapy is now recommended by some Swedish guideline, and it is telling to preserve. They plan to preserve capillary colloidal pressure and reduction of the capillary hydrostatic pressure. By this way, they try to prevent the brain edema and to reduce fluid shifting from the capillary to the brain parenchyma. So this is not commonly used therapies, but it can apply because study has seen that cerebral perfusion pressure more than 50 to 70 is a good range for maintaining cerebral autoregulation or cerebral hemostasis. So for decreased hydrostatic pressure, they're using metoclopramide type drugs, and for preservation of osmotic pressure, albumin, blood pressure are recommended. But this is not a commonly used therapy. We mostly use osmotic therapies, hyperventilation technique, induce coma, all these things. Now, cerebrovascular accident, artery occlusion in the ischemic stroke results in decrease or loss of blood supply within the area of the brain. This creates an infracore surrounded by penumbra, a zone of decreased perfusion that is functionally impaired by possibly salvageable. So, we are our target, as we all do in ischemic CVA, to prevent these things. So, cerebral blood flow within the infracore tends to be less than 10 ml per 100 gram per minute, resulting in permanent neural loss. In penumbra area, it can be 10 to 20, and prompt reperfusion with thrombolysis or thrombectomy will restore the function, so minimal the brain damage. Perfusion CT or MRI scan help detect penumbra as well as the therapeutic windows. Autoregulation is usually disturbed in stroke such that blood flow is strongly pressure dependent. We have already discussed. In case of subarachnoid hemorrhage, it causes direct local tissue disruption and elevation of the ICP, as well as the local vasoconstriction. Beyond contributing to the acute elevation of ICP and decreased CCP, subarachnoid hemorrhage is also infamous for producing cerebral vasospasm. Vasospasms peak, we all know, within the 5 to 7 days of the hemorrhage and last for several days, around 20 days, contributing significantly impaired cerebral blood flow and leading to delayed ischemic neurological deficit. So transcranial Doppler is used for and development of the vasospasm, and neponemine is a therapy to counteract that. Brain tumor, actually tumor change the local cerebral hemodynamics in several ways, like mass effect, angiogenesis, and breakdown of blood-brain barrier. Like leaky blood vessels in the high-grade gliomas can contribute vasogenic edema and as well as increase the ICP. Preoperative perfusion imaging assists the defining tumor margin and blood supply characteristics with intraoperative preservation of the surrounding functionally important brain tissue. Angiogenic therapies work toward the modulation of abnormal tumor perfusion in selected cases. Global cerebral ischemia. After cardiac arrest, there is a global hypoperfusion. Also hampers the brain. The hippocampus, cortex, and basal ganglia is very sensitive for this global in this situation. Neuronal loss results from reperfusion injury, oxidative stress, and microvascular thrombosis. Targeted temperature management and perfusion of the brain are key components for enhancing neurological recovery following global ischemic insult. Comprehensive such pathological alternation between this condition allows for specific therapeutic approach to reduction of the injury and encourage the recovery. Hydrocephalus and CSF disorders. Increasing CSF volume with the obstructive or communicating hydrocephalus boost ICP, increasing cerebral perfusion pressure and impaired perfusion. These features can be we can clinically we can see as an altered consciousness, papilloedema, and bulging frontal line in case of infant. So CSF diversion with ventriculostomy or shunt insertion, normalizing pressure dynamics. So monitoring of ICP and CCP is important for this patient, particularly post-operative period. The monitoring of hemodynamics. There is separate class actually for monitoring of cerebral hemodynamics. I just charted down just important thing like ICP. For ICP, what we can all monitor, like there is invasive ICP monitoring and non-invasive ICP monitoring. Among invasive, it is EVD, intraventricular micro sensor catheter, like that. CT brain phase contrast, MRI, papillometry, ONSD, eh, NIRS, cochlear microinfrared, and non-invasive therapy. For cerebral blood flow, xenon CT, NIRS, TCD, all these things are we can use. Cerebral oxygenation for jugular valve oximetry, PbTO2, NIRS. This we can use these things. And for cerebral metabolism, similarly, cerebral microdialysis, PET-CT, SgPO2, BbO2 can use. For cerebral hemodynamic monitoring, there is a now approach multimodal monitoring. So multiple, there is a modern neurocritical care is relies on integrating multiple monitoring modalities to provide a comprehensive picture of cerebral physiology. So commonly we use ICP, brain tissue oxygenation, oxygen tension, TCT, NIRS, microdialysis with ECG, and these things give a overall idea of the compact idea of the brain function and guiding the personalized therapeutic strategy. So again, I'm not going to details of this monitoring of the cerebrovascular hemodynamics because there is a separate class in next class. So this is the important that commonly used monitoring tool are used and their specificity, sensitivity, limitation, all is documented in this chart. So after take-home points, we have to know the clear cerebral physiology understanding is important. Cerebral blood flow, cerebral perfusion pressure, and ICP are interconnected. Cerebral autoregulation has a key role for maintaining cerebral physiology, and multimodal monitoring allows the real-time correlation of perfusion metabolism and help detection of deteriorating brain function and guiding personalized therapeutic management.
Well, thank you, Dr. Devottam, for a detailed lecture on cerebral hemodynamics. Does anybody have any questions for all the fellows here? Any questions from your end? Otherwise, I go on to mine. You can share in the chat box if you have any questions, or you can just unmute yourself and ask. Okay, Dr. Devottam, you talked about cerebral autoregulation. I think one of the most important concepts in neurocritical care. Now, can you just tell me and the audience, if the cerebral autoregulation is impaired, what actually happens? What is the consequence of an impaired cerebral autoregulation? Why is it that important to you? Can you hear me, Dr. Devottam?
Yes, ma'am.
I
Actually, ma'am,
wanted to, yes.
Uh, actually, there is a relationship between, as we show in this graph. Uh, Sorry.
That's
Uh,
okay. You continue speaking. Yes.
yeah, there is a relationship in cerebral blood flow and blood pressure. If this autoregulation curve, autoregulation is lost or impaired, so the flattening plateau phase will not be there. So there is a passive pressure response. I mean, in case of high blood pressure, the cerebral blood flow will increase, and in case of low blood pressure, there is a reduction of the cerebral blood flow. Now, if there is a high blood pressure, that causes increased cerebral perfusion pressure, and increased cerebral perfusion pressure leads to increased cerebral blood flow, and thus there is a development of the vasogenic edema. So, and if in case of hypotension, there is a low perfusion to the brain, and that can lead edema, ischemic episode to the patient. So that both of these things can lead to damage of the brain.
Yes, very good. So now what I want to ask is, practically speaking, how can you assess whether your patient has an intact autoregulation or not?
That's, I mean, there is no such tool to check practically how much it is brain having or maintaining its auto regulation or not. We can, I told this, there is a multimodal approach. We can check about the cerebral vasospasm by doing TCD. We can check the ICP. We can monitor the
Dr. Gautam,
ICP.
listen to me. Listen to me. No. I'm talking about autoregulation. Have you gone through the civic guidelines? The civic guidelines for TBI? Have you gone through them?
Not
Yes or
right
no?
now.
Forget about your slides.
No.
I'm asking you a question. So if you've gone through the
And
civic guidelines, you would find in one of the tiers that they ask you to assess the brain autoregulation with a MAP challenge test. Has any one of you read about it? How do you
Uh,
assess autoregulation? Yes, Rohan.
Ma'am, in civic guidelines in tier 2, we have the MAP challenge test. So
Yes.
basically, first of all, it has to be performed in presence of an experienced physician who has already performed this test.
Mm-hmm.
And during this MAP challenge test, we do not have to change any tier management. All the hemodynamics and basic homeostatic parameters have to be kept constant. The underlying principle is we try to increase the mean arterial pressure by 10 mmHg and maximum up to 20 mmHg, and then we assess the response to it via invasive intracranial pressure monitoring. If increasing the MAP, does it leads to increase in intracranial pressure or whether it remains constant? If it is constant, then the autoregulatory capacities are working.
Okay, that's very good. So autoregulation, Debotam, is practically maintaining your maps if even if the ICP is more or less or whatever, isn't it? So the brain is actually regulating itself against an increase in pressure. So that is if you have an invasive ICP monitoring in place, you can give a map challenge test to the patient and see whether the autoregulation is intact or not. Now, any comments about the PRX, pressure reactivity index that we talk about? That is the way to assess autoregulation. Do you have any idea about the PRX or pressure reactivity index, what it is, and how do you interpret it? A positive pressure reactivity index and a negative pressure reactivity index and the U-shaped curve. Any idea about that? Anybody? So pressure reactivity index is actually you can calculate only with the help of a special software. So it is the reactivity to the pressure, and you measure it with the help of an invasive ICP monitor. Now, a Cambridge-based technique, Cambridge University has actually devised it, and they have given a software through which you can calculate the PRX. But you guys should have an idea of what is a positive pressure reactivity index and what is a negative pressure reactivity index for sure. Okay, tell me, what are the other ways you can assess autoregulation? I think you talked about it in your presentation as well. How can you assess autoregulation with the help of TCD? Debutam, are you there?
Yes, ma'am.
So how do you assess autoregulation with a TCD?
Actually, PCD, we need to check the cerebral vasospasm we used to do for subretinal hemorrhage patients.
That's okay.
And immediately,
That is a different thing. You said that you can check for autoregulation with the help of a TCD. So dynamic autoregulation assessment with TCD, static autoregulation
flow,
assessment with TCD.
it is flow velocity and PI. Through it, we can check the ICP
No, 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 no.
by which we can.
Cuff inflation test and all of those you haven't read? You are the exam going candidate, isn't it, in the next month?
Actually,
Anybody
ma'am,
else?
this
Anybody else can talk about this?
favorite topic in my train, that's why I do not go to that.
Athara is here. Athara, Lenin, Sanchi. Sanchi, your comments on this? Autoregulation is one of the most important topics, and the examiner is definitely going to ask you that. So you should know everything about autoregulation. You're doing a fellowship in critical care, neurocritical care.
Yes, ma'am. There are two states in which there is a static autoregulation which can be done
Mm-hmm.
and dynamic autoregulation that is seen.
Mm-hmm.
So in static, what happens is we see it measures the overall kind of capacity of the brain. So whenever there is a blood pressure change, so there is an index that we see, especially the estimated cerebral vascular resistance to that of the map. So whenever what we do, we take the TCD machine and we see the map. So if the map and the TCD flow velocity that is seen in the middle cerebral artery, that is we see from the temporal window, ma'am. So the middle cerebral artery, we see the map and the TCD flow, and safely we can see that if there is any kind of lower blood pressure, so we can see if we are giving any phenyl, if there is this cerebral vascular resistance which can be seen, we do it by map upon blood flow. So whenever if we see there is a low blood flow and there is a lower map, that is we can see the ratio that is for the cerebrovascular resistance.
Sachi,
And if there is
how do you test the autoregulation? What are you saying? How do you test? What are the tests known as? How do you test for dynamic autoregulation and how do you test for static autoregulation? You are on the right track, but you're not giving me the exact points. Anybody else? You guys have to read about this, okay? Debuttam, you are the exam going.
Yes,
Sachi,
ma'am.
your exam is done, I think. Or you are the exam going.
exam going, ma'am. Yes, ma'am.
Okay,
Exam
so
going.
you have to read about this. Okay, Debuttam, next you tell me about hyperventilation. So you would know hyperventilation is one of the quickest ways to bring down your ICPs, is it?
Yes, ma'am.
Okay, so you have to tell me the mechanism first of all.
In hyperventilation, there is a washout of carbon dioxide, and that causes the diminish the pH of outside the brain tissue. The
Hmm.
local pH is coming down. There's a local alkalosis of the outside of the extracellular alkalosis, and that causes the release of the I mean, vasoactive products, and that can lead to vasoconstriction. It's a cerebral vasoconstriction.
Cerebral vasoconstriction, what does that do?
Maintain the cerebral blood flow, ma'am.
So how? How? So vasoconstriction does what? Fill in the gaps, na? Cerebral vasoconstriction
Perfusion
would
pressure.
cerebral vasoconstriction would reduce the cerebral blood volume. And because
Yes,
of a
ma'am.
reduction in cerebral blood volume, the ICP would fall. Okay?
Hmm. Hmm.
Okay. Now, prolonged hyperventilation is not helpful. Why? It may, in
No,
fact,
ma'am.
be
Actually, the
detrimental. Why?
compensatory mechanism will be worked by that time. So the effect of the alkalosis will be gone because the body will try to overcome the alkalosis uh, and so normalize the pH. So the reversal will be occur after 8 to 12 hours.
8 to 12 hours. What is transient hyperventilation? Okay,
For
hyperventilation in the first 24 hours of TBI. Is it recommended or is it not recommended?
acute reduction of the ICP, it is recommended like prior to OT operation we used to do
No, I'm
for
asking you, a TBI patient has come to you in the ICU. I'm not talking about decompressive. I'm saying a patient of TBI has come to you. Is hyperventilation recommended in the first 24 hours or not? Anybody? Exam going children, please, I need answers from you.
Ma'am, it is recommended only up not beyond 6 hours. Should not be done in traumatic brain injury
Now,
patients.
if you have gone through traumatic brain injury physiology, it is generally recommended that if your patient is on a conservative treatment with severe TBI, you should refrain from hyperventilating the patient in the first 24 hours for the reason that the patient is already, the brain is ischemic. You cause more vasoconstriction and the brain becomes more ischemic. So you would find
Yeah,
statements like avoid hyperventilation in the first 24 hours after TBI.
we maintain the PCO2 till 35 to 45 minutes in such cases. The TBI we do not increase.
Okay. All right. So is prophylactic hyperventilation recommended, Debottam?
no, madam.
I don't know
Prophylactic
what my ICP
hyperventilation.
is. Should I prophylactically hyperventilate so that the ICP does not increase?
No, there is no rule. It's not recommended for
So
prophylactic
all of you,
hyperventilation.
yes, all of you should remember three P's. No prophylactic hyperventilation, no profound hyperventilation, and no prolonged hyperventilation. Prophylactic, profound, and prolonged. All 3 points you have to remember. Prophylactic, prolonged, profound hyperventilation should not be done for the reason that Debottam just described. Okay. Now, does oxygen have any influence on your cerebral blood flow?
There's a hypoxia can cause vasoconstriction, cerebral vasoconstriction, when it's not
Constriction
as
or
much as
dilatation?
PCO2. Ma'am.
Constriction or dilation?
dilation, sorry. When it is less than 50 PCO2 level or oxygen saturation is less than 80%, and then it can lead to cerebral vasodilation. But it's not hypoxia, hyperoxia is not much role, and even oxygen is not that sensitive like carbon dioxide for brain tissue.
Okay, very good. Now, in neuro ICUs, if you all have worked in neuro ICUs, we are extremely skeptical about a patient getting fever. So we are extremely hyper that the patient should not have any fever at all. What is the reason?
Increased temperature can lead to increased cerebral metabolism, ma'am. So that increase the oxygen consumption much more. So that can lead to increased cerebral blood flow and increase the pressure too.
Okay, very good. A similar effect is exerted by what another physiological entity? CMRO2 is increased by one, fever. Two is?
Seizures.
Yes,
Seizures.
seizures. Okay,
Either,
very good.
either.
So anything that increases your CMRO2 is strongly discouraged. Now, what decreases your CMRO2? How do you decrease CMRO2 in your patients?
Sedation, ma'am. I mean,
Sedation, very good sedation. All right. So you have certain tiers of therapy while you are managing your ICPs. Out of which, according to me, the most important is tier 0. What is tier 0, Debuttam? What is tier 0 management of ICP? Anybody?
Ma'am, tier 0
doc-
is basically maintaining the homeostasis of the patient, basic physiology. You have to optimize
Very good.
oxygenation, head elevation, neurological monitoring, optimal cerebral perfusion pressure,
And how does
adequate
head
sedation.
elevation help? Debuttam, how does head elevation help? What does head elevation do? We usually say that in neurocritical care, the head end of the bed should be at least 30 degrees. Is it?
yes,
How does that
ma'am.
help? How does that help?
If we kept the head in lower side, there's a chance of more blood flow to the brain.
Okay, no, how
So
does that
that
help?
can,
If you elevate the head end of the bed, how is it going to help you?
for
So, ma'am,
drainage of the venous.
basically,
It improves venous outflow, ma'am.
venous
Exactly. It
outflow is
improves
diverted to
venous
other
out.
systems of the body, and hence it reduces the blood flow, and hence we reduce the ICP.
Very good. So the same principle applies to avoiding tight tube ties, keeping the head central, no kinks. Isn't it? All these things come in your tier 0. The reason is you are maintaining your venous drainage so that the blood volume is not increased inside the brain. And that helps you in reduction of ICP. Okay. Yes, Rohan, what else in tier 0?
Ma'am, maintaining adequate cerebral perfusion pressure of more than 60, avoiding anemia, maintaining HB of more than 7,
So how do you maintain your CPP above 60 in tier 0? What's the
adequate
crude way to do it?
volume resuscitation.
Debuttam, what is CPP equal to?
MAP minus, oh, sorry.
Okay, so ICP at this stage, you may not be very sure what are the values. What you can do is maintain your maps. So
MAPs.
tier 0 is actually avoiding any kind of hypotension. Okay?
Yes, ma'am.
Avoiding any kind of hypotension is the key. Okay, what else?
Uh,
अभी हमने बात करी preventing seizures,
we can consider anti-seizure medical prophylactic.
treat fever if present.
Maintain
There is
adequate
one more point
oxygenation.
which says avoid hyponatremia. How does that help, Debuttam? Avoiding hyponatremia is a tier 0 measure. How does that help?
cerebral, when there is hyponatremia, there is a chance of development of cerebral edema.
Yes, how?
I mean, osmolar effect,
Exactly. So now my next question is, how do your osmotic agents act? How do they help you?
like
What is the
mannitol
mechanism?
and yeah,
Yes, what is the
3%. They
mechanism?
draw the blood, fluid from the brain tissue or brain cell and reduce the cerebral edema. And
Reduce cerebral edema. So mannitol versus hypertonic saline. How do both of these act? Do they act differently? Mannitol is sugar. Hypertonic saline is salt. So we are taking two different compounds altogether. One is sugar, one is salt. How do they help? What is the mechanism of action?
Mannitol doing diuresis, I mean,
Okay, what does it
and
do in brain? अभी बताया तुमने.
osmolarity effect of is large molecule and take the fluid from cellular intercellular fluid.
Okay, and what does hypertonic saline do?
3% initial, I mean, hypertonic saline.
HTS causes volume expansion. Basically, it pulls the fluids into the veins.
Same
Into the
mechanism, and
veins.
both of them increase the osmolarity.
Yes, they increase the osmolarity. Yes, very good. Okay, Debuttam, you have to tell me hypertonic in a patient of AKI. Would you prefer hypertonic saline or would you prefer mannitol?
Hypertonic saline. Mannitol
Okay.
can cause, is a nephrotoxic agent, so it can cause.
Okay, my next question is, do you actually need anything, any kind of hyperosmolar agent in AKI? Do you actually need anything? Why am I asking this? What are the constituents? I mean, what is osmolarity? What ions in the body contribute to the serum osmolarity? What
Sodium.
active ions? Yes. What?
Sodium.
Sodium, glucose,
very
and
good.
urea.
Okay, so sodium,
Urea.
glucose, and urea. Now,
Urea.
one of your agents is increasing sodium, contributing to tonicity, right? Now, in AKI, urea is high. So what will that do? It will naturally increase the tonicity. Is it? Do you really need a hypertonic, hyperosmolar agent in this case? This is what I'm asking you. You got my point?
Yes, ma'am.
So basically, your patient might not need any hyperosmolar agent at all because the urea levels are high, isn't it? And if at all you want to administer, you would avoid giving mannitol and go for hypertonic saline. But be careful, actually. This is what I want to stress on. Okay, what is osmolar gap, Debuttam?
Yeah.
Measured minus calculated osmolarity.
Okay, so what does that tell you? Why is it done?
Basically, ma'am, what we are trying to find out with osmolar gap is any unmeasured cation. For example, if the patient may be having hyperglycemia, so the calculated and measured osmolarity will be different. So we need to, in order to
And if the
monitor
patient, 1 minute, if your patient has hyperglycemia, his calculated and measured will be different. Where is it used? You tell me. Where do you use the osmolar gap?
to monitor
You use osmolar gap in order to monitor the unmeasured cation.
unmeasured, like
Glucose. Glucose you already have in the calculator. Urea, sodium, and glucose you already have in that equation. Those are the measured ions of the body, not the unmeasured ones. So while you're using mannitol, you are giving an extra ion which you have to see by your measured osmolarity. Because of the presence of mannitol in blood, the measured osmolarity would be more, while the calculated osmolarity would be less. And then the osmolar gap would be high. All right?
Yes,
so if it is exceeding 20, we recommend not to use any more of mannitol. So actually, it is not the serum osmolarity which is the determinant of mannitol not being used. It is actually the high osmolar gap that tells you that no more mannitol is effective. Debuttam, you got my point?
Yes, ma'am.
Okay. Okay. Anything else? Anything else? बहुत discussion हो गया शायद. I think we have to end the class now. 8:25. Okay, so Debuttam, you have presented things very well. The only input is that all of you should present in points, not in paragraphs. Please don't copy and paste paragraphs in your slides. Please make points out of whatever you want to convey to us. You know, it becomes very monotonous to have content heavy slides on the screen. You actually fall asleep. Okay, for all of you who are going to present next, please make points and then present so that the takeaway message is loud and clear. Okay, thank you so much, Debuttam. And thank you guys for being here.
Thank you, ma'am.
We'll just end the class now. Okay.
Thank you, ma'am.
Bye bye.